All right, let's dive into one of the most fundamental skills you'll use in pediatrics, assessing normal child growth. Think of this as your practical guide, your field manual, for interpreting the clues that are hiding in plain sight on every single growth chart.
So, you've plotted that point on the chart, but what does it really tell you? Honestly, not much. A single measurement is just a snapshot, and it's a classic trap. The real story, the clue you're actually looking for as a clinical detective, is hidden somewhere else entirely.
And here it is. This is the absolute core concept for today. It's not about where a child is on the chart at any one moment. It's about the direction they're heading. The pattern over time, that's growth velocity. And it is, without a doubt, your most powerful tool for telling the difference between a healthy, thriving kid and one who might have something else going on.
So here's our game plan. We'll start with why growth is the ultimate vital sign. Then we'll cover the key drivers and milestones. After that, we'll get into the nitty-gritty of the growth chart itself, walk through a systematic evaluation, and then, the most important part, we'll learn how to tell the difference between normal variations and serious red flags.
Okay, first things first. Let's really establish why we call growth the ultimate vital sign. Because before you can spot something that's off, you have to have a rock-solid understanding of what a healthy trajectory even looks like. So what do we even mean by normal growth? It's not just about getting bigger. It's a dynamic process. And when that process is on track, it's one of the most reliable signs we have that a child is healthy, well-nourished, and it's basically a summary of their entire well-being packed into a few simple measurements.
And what's driving all this? Well, it's this really fascinating handoff. See, at birth, a baby's size is mostly telling a story about the mom and the uterine environment. But then watch what happens. By the time that kid is 2 years old, the correlation with their final adult height shoots up to 0.8. That's genetics grabbing the steering wheel and saying, okay, I'll take it from here.
Now that we know what's in the driver's seat, let's map out the journey. We're going to look at the key drivers and milestones. These are the predictable patterns, the signposts you'll be looking for along the way.
Now this is a huge clinical pearl. Growth is not a smooth, straight line. It's what we call pulsatile. Kids have these big growth spurts and then nothing. Periods of literally no growth. It can also be seasonal. They often shoot up in the spring and summer. Just knowing this will save you so much trouble when you're reassuring anxious parents who swear their child hasn't grown an inch all winter.
For infants, weight gain follows some really simple rules of thumb. They should be back to their birth weight by about 2 weeks old. They should double it by 4 months, and they triple it by their first birthday. These are your go-to checkpoints for that first year of life.
And what about height? The milestones here are just as critical. A baby grows an incredible 25 centimeters in that first year. Think about that. And by 24 to 30 months, they're already about half of their final adult height. After that, things kind of settle into a steady pace of about 5 centimeters a year until puberty hits.
All right, let's talk about the growth chart itself. This is your primary investigative tool. It's your magnifying glass, your stethoscope for growth. And knowing how to use it correctly, well, that's non-negotiable.
The very first step is picking the right chart, because trust me, they are not the same thing. The WHO chart, which we use for kids under 2, is a standard. It's prescriptive. It shows how children should grow under optimal conditions, specifically based on breastfed infants. The CDC chart for older kids is a reference. It's descriptive. It just shows how a specific group of kids in the US did grow. That difference is absolutely critical.
And here's why it matters so much. If you use the wrong chart, you can end up making the wrong call. A perfectly healthy breastfed baby plotted on a CDC chart might look like they're failing to thrive after a few months. On the flip side, a formula-fed baby on a WHO chart might look like they're growing too slowly at first. That is exactly why the CDC is crystal clear on this. For every single child under 24 months, you use the WHO growth charts. Period.
Okay, so you've got the right chart in your hands. Now it's time to learn the art of the evaluation. Let's walk through the systematic investigation you're going to perform every single time. It's really a 4-step process. Simple. First, you gather your intelligence. Take a great history. Second, you collect your evidence with accurate measurements. No shortcuts here. Third, you plot that data on the right chart. And finally, you analyze everything by assessing for proportionality.
Your history is all about getting the context. What were the birth stats? How tall are the parents? And were they maybe late bloomers? Any prenatal exposures we need to know about. And of course, you're always screening for those red flag symptoms of underlying disease, things like persistent vomiting or diarrhea. Every single piece of this puzzle matters.
Now, once a child hits 2 years old, our main tool for assessing proportionality becomes the body mass index, or BMI. And no, it's not just for adults. In pediatrics, BMI is our go-to screening tool for everything from undernutrition to diagnosing overweight and obesity.
And here are the categories you need to know. If they're under the 15th percentile, we start thinking about undernutrition risk. From the 85th up to the 95th, that's overweight. And 95th percentile or greater is the clinical definition of obesity. These aren't just random lines. They are real, clinically significant thresholds.
Okay, this brings us to the most important part of the entire evaluation. This is where you put all the clues together and crack the case, telling the difference between a normal variant and a true red flag.
This table is pure gold. It helps you sort out two super common and totally normal causes of short stature. Now look closely. In both familial short stature and constitutional delay, the key is that the growth velocity is normal. So what's the difference? Look at the bone age. Bone age is just a measure of skeletal maturity from a hand X-ray. In a kid with constitutional delay, a late bloomer, their bone age is delayed. That means they just have more time left to grow. They'll get there just on their own schedule.
Here's a number I want you to burn into your memory. In a kid before puberty, a height velocity of less than 5 centimeters per year is a major red flag. This isn't a normal variant. This is a signal that something is slowing them down, and it absolutely needs a closer look.
And here's the equivalent red flag for weight. If a prepubertal child is gaining less than 1 kilogram per year, that should set off alarm bells. You should be thinking about nutritional issues or other problems. Again, it all comes back to velocity being your most sensitive indicator.
And this quote really brings it all home. Never, ever underestimate the power of that squiggly line on the growth chart. A little deviation, a change in that velocity, it can be the very first clue your patient gives you that something is wrong, way before any other symptoms even show up.
So we'll end on this thought. You now have the tools, the framework of a clinical detective. You know that the pattern is everything. You know the red flags to watch for. The only question left is, what are you going to find on your next patient's chart?